Good afternoon. I'm Commander Anna Kahn, Associate Director for Communication with the Division of Environmental Health Science and Practice in the National Center for Environmental Health at the Centers for Disease Control and Prevention. I'd like to welcome you to today's Nexus webinar. CDC and HRSA partner for childhood lead poisoning prevention, guidance for clinicians. There will be a presentation and a Q&A session with panelists. All participants joining us today are in listen-only mode. Closed captions are available for this webinar. Next slide, please. Today's Nexus webinar will be available to view on demand a few days after this webinar. You can find the video recording of today's webinar at CDC's Nexus webpage at cdc.gov/NCEH/EHNEXUS, or you can scan the QR code. Next slide, please. You may submit questions at any time during today's presentation. To ask a question using Zoom, click the Q&A button at the bottom of your screen, then type your question in the Q&A box. Please note that we often receive more questions than we can answer during a live session. For insurance coverage related questions, please contact the Centers for Medicare and Medicaid Services. For regulatory questions, please contact the Food and Drug Administration. If you're a member of the media, please contact CDC Media Relations at media@cdc.gov or at 404-639-3286. Next slide, please. Now I would like to welcome Dr. Erik Svendsen, the Director of CDC's Division of Environmental Health Science and Practice in the National Center for Environmental Health, and Dr. Michelle Chambliss, the Director of HRSA's Federal Torts Claim Act program, to provide opening remarks for today's Nexus webinar. I'll turn it over to Dr. Svendsen and Dr. Chambliss for opening remarks. Dr. Svendsen, the floor is yours.
Thank you, Commander Kahn. So thank you to all of you for joining us for this CDC and HRSA webinar on lead. It's a pleasure to be here with you today and with our HRSA colleagues to be able to talk with you about this very important topic. So in 1991, CDC began funding state and local childhood lead poisoning prevention programs. So over the last 30 years, the United States has seen decreases in childhood lead levels. But we all know that there is no safe level of lead in children's blood. And we need to continue to eliminate lead from the exposure to children across the country. So children have been exposed to lead from several different sources, ranging from leaded paint in their walls to lead from older toys and some herbal supplements even in some locations. So CDC is leading the effort to prevent childhood lead exposures from across the country. Our lead poisoning prevention program is working to eliminate childhood lead poisoning as a public health problem through promoting blood lead testing, monitoring trends in blood lead testing levels among children, linking lead exposed children to recommended services, and supporting targeted population-based interventions. So we at CDC, we currently fund 62 state and local public health programs who conduct lead poisoning prevention activities in 47 states, 12 major cities and counties, Washington, D.C., and Puerto Rico. Each of our federal programs bring a unique perspective and supports our collective mission to reduce childhood lead exposure across the country. So CDC has contributed to great strides in lead poisoning prevention. We are supporting efforts to eliminate lead in paint, drinking water, and consumer products to reduce exposures where children live, learn, and play. So our website provides valuable resources for families, healthcare providers, and public health professionals and others. We provide ongoing assistance for our federal programs as they implement lead poisoning prevention activities in their communities. And we're looking forward to hearing more about this in today's webinar. I'll hand it back to you, Commander Khan. Thank you for your opening remarks.
Thank you, Dr. Svendsen. And now I'd like to turn it over to Dr. Chambliss. Dr. Chambliss, the floor is yours.
Thank you, Anna. Good afternoon. It is my pleasure to welcome you to this HRSA and CDC joint presentation and discussion on childhood lead poisoning prevention and guidance for clinicians. My name is Dr. Michelle Chambliss, and I am the director here for the Federal Tort Claims Act at HRSA. And lead poison is something that is overlooked, often overlooked, not seen as a high priority on the list of health concerns that are preventable. It is somehow seen as an issue of the past, but still today, nearly 3.6 million US families are still at risk of permanent harm to their children because of their homes are contaminated with lead-based paint. Lead poison can affect the intellectual development, growth, and hearing of children, and can lead to many other health issues. In a recent paper, Blood Lead Testing Amongst Medically Underserved and Socially Vulnerable Children in the United States, 2012 to 2017, it focused on blood lead testing performed by health centers across the country. Unsurprisingly, the study of UDS data and responses from the self-report Health Center Patient Survey during this time period supported the fairly well-known fact that children from low-income households, those living in housing built before 1978, and those who identify as African American, immigrant children, and other non-white Hispanic children, which is our health center patient population, are at greater risk for lead exposure. Between 2014 and 2015, 1.1 million out of 1.5 million eligible children 12 to 60 months of age self-reported receiving a blood lead test at an HRSA-funded health center. There was a significant higher proportion of children with blood lead tests amongst urban health centers and amongst those who reported health centers as their usual source of care. The total health center population of children younger than 72 months who reported testing increased from 2.6 million in 2012 to 2.9 million in 2017, and 34% increase in blood lead testing at HRSA-funded health centers over the same time period. That is fantastic results. But that was 2017. This is 2022. Since 2017, we have experienced a worldwide pandemic that significantly reduced patient visits, strains, the cold, and influenza.
Please stand by. I think we're having a technical issue. One moment, please. Please stand by while Dr. Chambliss tries to reconnect. We'll give her about a minute and then we'll move on to welcome our presenters. Okay, let's go ahead and move on, and we can gather the additional remarks that Dr. Champlin would like to provide towards closing remarks. So next slide, please. Thank you. Okay, so I would like to welcome our presenters for today's Nexus webinar. We're pleased to have with us our first presenter, Dr. Paul Allwood. Dr. Allwood is the branch chief of the Childhood Lead Poisoning Prevention Branch at CDC's Division of Environmental Health Science and Practice. Our second presenter is Dr. Arthur Chang. Dr. Chang is the Chief Medical Officer at CDC's Division of Environmental Health Science and Practice. Now I'll turn it over to Dr. Allwood. Dr. Allwood, the floor is yours.
Thank you very much, Commander, and welcome everyone. It's a real pleasure to see so many people in the virtual audience, and I do hope that we will get Dr. Chambliss's remarks. He's giving a really nice glimpse into the HRSA world. So moving on, can you please move to the next slide? Okay, so let me just say, at a high level, what we're going to try to accomplish today. We're hoping that by the end of the session, people will have a better understanding of CDC's Childhood Lead Poisoning Prevention Program, otherwise referred to as the CDC CLIP, including what our mission, vision, and strategic priorities are. We're hoping to also share, some insights into the epidemiology of lead exposure as a public health problem, and key ways that we can prevent children from becoming exposed to lead or poisoned by lead. And then, we also want to, raise awareness about the need to test children who are at risk for lead poisoning. And some might even argue testing all kids is necessary. And then finally, we'll get into some of CDC's recommended actions based upon the blood lead level that's detected in a child. Next slide. All right, so as you've heard before, CDC has had a long history of working to prevent childhood lead poisoning prevention, and working to prevent childhood lead exposure, I should say. And our strategic vision is to eliminate childhood lead poisoning as a public health problem. And we're committed to doing that by decreasing blood lead levels in children and eliminating disparities in blood lead levels by race and ethnicity and socioeconomic status. Next slide. We are pursuing 4 core strategies to achieve the mission and the vision that I just spoke on. First, we're trying to strengthen blood lead testing and reporting. We're also trying to increase surveillance of blood lead levels. And we want to enhance the linking of children that are exposed to lead to recommended services and care. And last but not least, we are also actively promoting targeted population-based interventions that are aimed at primary prevention. Next slide. You heard a little bit about this when Dr. Svendsen spoke, but we're really proud and very pleased that we have a very expansive set of partners that we do this work with. We currently fund 62 state and local programs that are involved in childhood lead poisoning prevention activities, which includes, like you already heard, all but 2 states that have no CDC funding currently. But I'd just like to share that as we speak, we are actively, and you can see those states here in white, state of North Dakota and the state of Arkansas. But we are working right now to try to fill in those gaps, and we're making pretty solid progress in that area. So the states that we fund are there are 2 types of funding arrangements that we have in place. We describe them as as component A funds and component B funds. The states are primary recipients of component A funds, and those funds are dedicated to surveillance and testing and linking lead exposed kids to appropriate follow-up and care. And component B funds are primarily, targeted towards local government entities and are more geared towards promoting local community-based interventions aimed at primary prevention. Next slide. I won't spend too much time on this slide, but this was just meant to kind of illustrate the point that was made earlier, that there's a lot of lead in our environment, and children can be exposed to it in a variety of ways. And this figure, was taken from a publication by UNICEF, which you are all encouraged to read if you haven't already done so. But some of the sources that are relatively common, or concerningly common, include paint in houses that were built before 1978, soil around homes that have deteriorated exterior lead-based paint. There's still leftover lead in soil along roadways, leftover from when lead was added to gasoline for passenger cars. And for the children who live within close proximity to certain types of airports that service piston engine aircrafts, there's also lead, in the soil and also in the air, around such facilities. But as you can see, there are various other sources within the homes. There's water. There's certain types of food or spices, and there are also medicines from different parts of the world that may contain lead. There's jewelry and toys that also contain lead, and also cosmetics. There are various cosmetics have been found to have high levels of lead, and also imported candy, have been found that has higher levels of lead than would be safe. There are also certain occupations that are known to be associated with an increased risk of lead exposure, and parents or caregivers who work in those occupations are likely to take lead home, and that can also be a source of lead exposure for children. Next slide. So there are two primary routes of exposure for children with respect to lead. The first is inhalation, and their lead dust and particles of lead from lead-containing materials that are deteriorating can be inhaled. And of course, the amount that's inhaled is a factor of the size of the particles and the age of the child and so on. But inhalation is a well-recognized route of exposure for children. Ingestion is the second route of exposure, and this is also a factor of lead-containing materials deteriorating and turning into chips or flakes. And as children move around, especially children that are just beginning to crawl, they sometimes come up on these lead particles, and they will eat them. And lead has a sweet taste. I've never actually tasted it myself, but you might imagine that something that's sweet tasting is going to be very, very appetizing. Our children will probably prefer to put things like that in their mouth. Next slide. So just going a little bit more, in terms of the risk profile for small children. They have the greatest risk of exposure, and also are at risk for the worst impacts, because their bodies are developing, their detoxification processes are not fully mature. They have behaviors that are kind of unique, such as mouthing, crawling around, they're closer to the ground, and so they'll breathe in dust a little more readily. They also absorb lead, more lead, per unit body size than adults. And studies have shown that 20 to 7% of ingested lead is absorbed into the body, with children absorbing a much higher proportion than adults. In fact, children can absorb as much as 40 to 50% of an oral dose of water-soluble lead, compared to adults who would absorb only about 3 to 10%. Children also have unique exposures that adults, don't, including they can be exposed through breast milk, and they can also be exposed transplacentally, because lead will cross the placenta. Next slide. So children exposed to lead can have, very, very serious health consequences. Very high lead levels, very high level exposures can lead to severe neurologic problems, including coma, convulsions, mood changes, abdominal cramps, and even death. I'm pleased to say that, these levels, this kind of exposure is relatively rare in the United States nowadays, but it is not out of the realm of possibility. Lower level exposures can have adverse effects on the brain, the nervous system, the kidneys, and the blood system, and also cause problems such as slowed growth and development, learning and behavior problems, hearing and speech problems as well. And it's important to note that children with chronic lower level exposure may have no, obvious symptoms, or may show no real distinctive signs. And so, such children, it may be unknown, the extent, the fact that they're exposed to lead may be somewhat, disguised for a period of time. Next slide. So this figure shows something that's encouraging on the one hand, but also, is somewhat concerning. And the good news part of this picture is that it shows that over the last 40 years, the average geometric mean blood lead levels in children in the United States have decreased fairly significantly, not very significantly actually. Blood lead levels declined from back in the when the 1976 to 1980 NHANES study was done. That's the National Health and Nutrition Examination Survey. The average blood lead levels at that time was about 15.2 micrograms per deciliter. And when we looked at the same survey data for 2011 to 2016, that level had decreased, that geometric mean level had decreased to only 0.83 micrograms per deciliter. And this is true, for both of these lines. The solid line, which represents kids, that are kids between 1 and 5, and the dotted line, which represents, older kids. So the overall decline in the percentage of children with blood lead levels that are above a certain reference value also changed. And this is what the bar shows. That going back to the 1976 to 1980 period, virtually all children had blood lead levels that were greater than 5 micrograms per deciliter. But by the time we got to 2011 to 2016, the prevalence of blood lead levels that were greater than 5 micrograms per deciliter was less than 2% among children, age 1 to 5. Next slide. So as I said before, this is the previous graph, showed you a very, very, positive and optimistic picture of what's happened on a population level with declines in blood lead levels. However, there is still significant disparities in exposures to lead and thereby in blood lead levels based upon geography, race and ethnicity, and poverty to income status. There are still many locations in the US where significant numbers of children are exposed to lead. And in fact, as you heard from Dr. Chambliss, young children that are at greatest risk are those who come from low-income households, are member of certain racial and ethnic groups. For example, children who are non-Hispanic Black had higher blood lead levels compared to children who were white in the analysis, in a 40-year analysis of the NHANES data, which was used to create that graph that I showed you on the previous slide. Children who are recent immigrants are also at greater risk for having been exposed to lead and having higher blood lead levels. And children who have parents or household members who are exposed to lead at work or through a hobby are at higher risk for lead exposure. Okay, next slide. Okay, I think we can skip this one over because I think I spoke on that previous slide. Sorry about that. Okay, so there are a number of ways that we can prevent child lead exposure. Primary prevention, which involves removing the lead hazard from their environment before a child is ever exposed to it. This is the most effective way to ensure that children do not experience long-term effects. So that's kind of the best preeminent strategy for dealing with the problem of lead exposure among children. If we can remove the hazards from the environment, then we prevent the possibility of long-term and sometimes irreversible health impacts. Secondary prevention includes blood lead testing and follow-up, with care and referral. Even though we are committed at the CDC to promote and encourage primary prevention to the extent possible, we are aware that there are still many children that have already been exposed, and so we need to identify them. We need to determine what their lead exposure is and connect them to the appropriate care and supportive services to minimize impact. Next slide. So some examples of primary prevention activities are, having homes that were built before 1978 inspected, and if lead is present, then having a certified lead abatement specialist remove the hazard or to have it properly mitigated. This is also, we get questions a lot. Well, what if I don't own my home? Of course, if you're renting, you're still at risk. And so then we would advise you to speak with your landlord to, have the home inspected and for abatement, steps to be taken. We also recommend cleaning floors, windows, including the window frames and window sills, and other surfaces that are regular places where lead dust could accumulate. Using soap and water to wash children's hands and toys very, very often. Leaving shoes, outside of the main part of the home, outside the door, or in areas where lead dust that's tracked in from the outside, it wouldn't get into areas where children live and play. We also encourage and recommend that bare soil, be covered with grass or mulch or wood chips to prevent children playing in the bare soil, and also as a way of reducing exposure to lead dust as the wind blows on those bare surfaces. Next slide. Lead exposure in children can be determined by a blood test, and there are two types of tests that can be used. However, sample collection, must be very carefully managed. And to that end, CDC has published, guidance, comprehensive guidance on how to properly collect a blood lead sample. So the two sample types are, as you see on the slide here, a finger prick or a capillary test or a venous blood draw. Other types of testing methods have been discussed or tried out, including testing for lead in saliva, in teeth, in bone, in hair. But there are challenges with these methods, and so CDC's current recommendations is that a blood lead test, a blood test, is the most reliable and valid method for determining lead body burden in children. Next slide. So we want children who are enrolled in Medicaid to get tested at 12 months and 24 months. Or if they have not been tested at those milestones, then they would be required to be tested between 24 and 72 months. And this is a CMS requirement. And I have to say, even though it is a CMS requirement, the level of compliance is very low. And so, that is one of the things that we have been concerned with and have been working with CMS, having discussions with CMS about how we might be able to increase rates of testing. Children that are not enrolled in Medicaid, the current CDC recommendation is that targeted testing of those children be carried out based upon risk, including socio-demographic and environmental risk. And then there are several states that have implemented universal testing for all children. And irrespective of risk, they have decided that they will test all of their children. Next slide. There have been, some challenges with, the guidance surrounding targeted testing. CDC published a fairly comprehensive guidance about how to do the risk assessment and, how to use a systematic approach to determine which children are at greatest risk for lead exposure and thereby should be screened and tested. However, a recent study has shown that as many as 60% of children enrolled in Medicaid, did not get tested as required. And one study from North Carolina indicated that about 30% of children with blood lead levels requiring some follow-up were missed, even with the application of the targeted testing methodology. Other concerns include that there are sources of lead exposure that are not paint, and they may not be easily captured in the risk assessment procedures. And so children who are exposed to those types of sources may not be seen as at higher risk, and so may not be tested. We also recognize that we know a lot about children who get tested. We don't know a lot about the children who do not get tested, and so this is an area that we're exploring more and hoping to learn more about to understand what are the potential risk factors among the kids who do not get tested. Next slide, please. So beginning in January, there has been, since January of 2022, there has been a shortage of the specimen collection tubes that are specifically developed for blood lead testing. And we heard about this at the CDC more recently, sometime over the course of the summer, and we were able to put together some recommendations, which you see on the screen, and which might be valuable to this audience of practitioners. Among other things, we recommend that our childhood-led poison prevention program and clinicians communicate with the labs about what the appropriate specimen requirements are, since these might change over time. We also recommend that, you know, the blood tubes that are used should have been manufactured specifically for trace element testing, or if not, they need to be pre-screened before being used as tubes for blood lead testing. We also recommend that if tubes are not available, then the labs might be able to discuss alternative approaches to doing blood lead testing. Next slide. So we are trying to, you know, work hard to, you know, lift up those testing rates. And some of the things that we're doing in addition to what I've spoken on before is that we are, you know, last year, almost exactly a year ago, CDC lowered the blood lead reference value. And I'll say a little bit more about that in an upcoming slide. And we're also pursuing improvements in our surveillance capabilities and methods to improve the kind of data that we're getting from the states, and to, you know, analyze them and understand, you know, what decisions can be made from them a little more efficaciously. We're also developing new training, which will be published, you know, very soon. We put out a set of vignettes, you know, based upon real world inquiries that we received at CDC, to highlight some of the lesser known ways that children can be exposed to lead. And we are expanding our outreach. You know, we're running ads in Medscape that encourage providers to test more. We put out an article in the AAP journal, and of course we're, you know, engaging with stakeholders and partners like HRSA. We've also been talking with Medicaid, you know, the pediatric environmental health specialty units, poison control centers, and others. Next slide. So over time, CDC has used, you know, various definitions for interpreting children's blood lead levels. And as you can see in this table, you know, going back to the 1970s, there are different ways that we interpreted blood lead levels. But as of 2012, CDC established a population-based blood lead reference value. The blood lead reference value is based upon the 97.5th percentile of the blood lead distribution in US kids between 1 and 5. And the data for calculating this percentile comes from the National Health and Nutrition Examinations Survey, or the NHANES. The initial level that was established in 2012 was 5 micrograms per deciliter, and that was based on data from the 2007 to 2010 NHANES. The blood lead reference value, as I mentioned earlier, was updated about a year ago, and it's now 3.5 micrograms per deciliter, and this is based upon data from NHANES 2015 to 2018. And it's important to note that the blood lead reference value, or the BLRV, is not a health-based standard or a toxicity threshold. It is a statistically derived reference value that allows CDC, federal partners, health departments, and others to focus resources on children with higher levels of lead in their blood compared to most other children. And I want to make a point of note, highlighted on the table, is the use of the term elevated blood lead level, and you can see that that was used somewhere between 1978 and 1991, and referred to blood lead levels that were greater than 30 micrograms per deciliter, and then greater than 25 micrograms per deciliter. So CDC no longer uses the term elevated blood lead level, and in keeping with that, in July of this year, the Council of State and Territorial Epidemiologists also changed the name of the condition that is under surveillance from elevated blood lead level to lead in blood. And, this is the basis on which the surveillance and epidemiology at the state level will be conducted. And, there's corresponding case definition and case reporting guidelines that were also published by CSTE. Next slide. And now it is my pleasure to turn over the podium to my colleague, Dr. Art Chan, who's going to be speaking a little bit more about medical guidance. Art, your floor is yours.
Great, thank you, Dr. Elwood. Good afternoon. I'm delighted to be here today and share with you an overview of the CDC recommendations for management of lead poisoning in children. Next slide, please. As a reminder, the CDC's recommended actions based on blood lead levels are listed on the CDC Childhood Lead Poisoning Prevention website. Clinicians should also consider state and local regulations, as reporting and referral requirements may vary depending on where you practice. So diagnosing lead exposure begins with obtaining a blood lead level, which will guide your clinical decision-making and recommended actions. So some examples of these actions are providing education to parents to prevent exposure to sources of lead around the home environment. And also, what does the new 3.5 micrograms per deciliter blood lead reference value means? Because this may be different than the reference ranges that are on the lab testing results, for example. Monitoring the child's growth and developmental milestones to ensure that they're not being impacted by lead or other preventable exposures. Other actions also include assessing the child's symptoms, because this may clue you in on a potential source for lead. For example, there's behavior such as pica or eating non-food substances. And another important action is a referral for the environmental home inspection through the local or state health department. For children with high blood lead levels, we want to identify the source and stop further exposure. And finally, initiating or referring for urgent medical treatment those children that have very high blood lead levels. So I will cover these actions in more detail in the context for each blood lead level category in the next few slides. Next slide, please. So first, I wanted to discuss a recommended schedule for obtaining a confirmatory venous sample. So confirmation using a venous sample is recommended if initial sample was a capillary sample or point of care test. That's because venous samples collected using the appropriate metal-free vacutainer tube have less chance of false positives or negatives, because it decreases the risk of lead contamination from the environment during the collection procedure. Confirmatory venous samples are also tested using more sophisticated laboratory techniques as compared to the point of care lead testing devices. And these may include inductively coupled plasma mass spectrometry or graphite furnace atomic absorption spectroscopy. The recommended schedule on this slide shows that the suggested time to confirmation testing, and you should also use your clinical judgment based on the child's symptoms for ordering a confirmatory test. So generally, the higher the blood lead level, the sooner you should obtain confirmation. Next slide, please. In the following slides, I'm going to review CDC's recommended actions for follow-up care and case management for children based on their confirmed blood lead levels. Keep in mind that providers should consider their state or local public health guidance when making these decisions. Since there is no safe threshold level of lead that has been identified, healthcare providers should initiate actions for children with any amount of lead in their blood. So for children with blood lead level below 3.5 micrograms per deciliter, a healthcare provider should provide anticipatory guidance and education about common sources of lead exposure and information on how to further prevent exposure. During your well child visits, you should check development to make sure that age-appropriate milestones are being met, and also discuss diet and nutrition with a focus on adequate iron and calcium intake. Diet and nutrition are important because we know that children who are deficient in iron and calcium absorb more lead that might be ingested. Also, conduct follow-up blood lead testing at recommended intervals based on the child's age. So I believe Dr. Allwood had mentioned this, but the Centers for Medicare and Medicaid Services requires all children enrolled in Medicaid to get tested for lead at ages 12 and 24 months, or ages 24 to 72 months if they have never been screened previously. For children not enrolled in Medicaid, CDC recommends focusing screening efforts on high-risk neighborhoods or individual risk factors such as the age of housing and other social and demographic factors. For example, certain imported spices have been found to contain high lead levels, so it may be important to keep that in mind. Public health personnel and healthcare workers should use local data to develop screening plans that are responsive to local conditions. In the absence of such plans, CDC recommends universal blood lead testing. Next slide, please. So for children with a blood lead level between 3.5 and 19 micrograms per deciliter, a healthcare provider should follow the recommendations for children with blood lead levels less than 3.5 micrograms per deciliter that we just discussed in the previous slides. And additionally, report the test results to your state or local health department. At these blood lead levels, it will be important to obtain an environmental exposure history to identify potential sources of lead and provide recommended actions on how to avoid further exposure. When asking about possible sources of lead in the home, also include all family members in the household because lead exposure is associated with certain occupations, such as auto repair, construction, or mining, and also certain hobbies like metalworking, artistry, firearm, target practice, hunting, or fishing. Also, the clinicians should arrange for an environmental investigation of the home to identify potential sources of lead as required by local or state regulations. So during an environmental investigations, professionals check the child's environment for possible causes of lead exposure and also recommend ways to further prevent lead exposure. Keep in mind that for blood lead levels less than 5 micrograms per deciliter currently may not trigger a Department of Housing and Urban Development environmental investigation when the housing is covered by the HUD's lead safe housing rule. Additionally, environmental investigations for this blood lead level category may vary based on the local requirements and available resources. Finally, provide follow-up blood lead testing at recommended intervals, which I'll show you in the next section. Next slide, please. For children with blood lead levels between 20 and 44 micrograms per deciliter, a healthcare provider should follow the recommendations for children with blood lead levels less than 19 micrograms per deciliter that we just covered. Perform a complete history and physical exam, assessing the child for signs and symptoms related to lead exposure. Arrange for or refer the family for an environmental investigation of the home and a lead hazard reduction program. Consider obtaining an abdominal X-ray to check for lead-based paint chips or other swallowed metallic foreign bodies which could contain lead. This is very important for young children who tend to swallow or eat non-food items. Children may also put in their mouths on surfaces that may be covered with lead dust. For these blood lead levels, it is important to contact a pediatric environmental health specialty unit, or PESU, or your local poison center for further guidance. PESUs provide information on protecting children and young adults from environmental hazards, including lead. PESUs also work with healthcare professionals, parents, schools, and community groups. Poison centers are staffed by healthcare specialists who can provide medical recommendations and consultations and operate 24 hours a day free of charge. Both PESUs and poison centers have information on specialized clinics that you can refer your patients for follow-up testing and medical management if required. Next slide, please. I'll discuss the recommended immediate actions for children with BLLs greater than or equal to 45 micrograms per deciliter. So these require urgent attention because it has the potential to be life-threatening. So the clinician should perform a complete history and physical exam, including a detailed neurological exam. As your blood lead level increases, the most crucial body system that's affected is the central nervous system. Acute neurological abnormalities is an indication for chelation therapy. Most of the time that will need to be done in an inpatient setting. And this is done in order to remove the lead out of the body as soon as possible. We would recommend to perform an abdominal X-ray and if needed, initiate bowel decontamination. Because remember that we want to stop any further exposure, even if we start chelation therapy. So making sure that there is no swallowed foreign bodies that may contain lead. If a patient exhibits signs or symptoms of lead poisoning, including confusion, weakness, seizures, coma, or has severe GI symptoms like nausea, vomiting, and abdominal pain, admit them to the hospital for medical monitoring and management. You should also consider admitting a patient to the hospital if a child's home is not lead safe and they are unable to find a source of lead-free living space. Source of lead exposure has not been identified, and there is a potential further exposure is also another indication for consideration to admit a patient to a hospital. At these high blood lead levels, clinicians may initiate GI decontamination or chelation therapy after consulting with a medical toxicologist or pediatrician with experience in treating lead poisoning. So for your awareness, GI decontamination is performed using cathartics like polyethylene glycol solutions or GoLily. Chelation therapy is performed using medications like DMSA, which is also known as Suximor. DMSA is the only FDA-approved oral medication for lead poisoning. The usual course of treatment is 19 days. There are also 2 other FDA-approved medications, but both of these are usually used in an inpatient hospital setting. These are used there because they're given intravenously or intramuscularly. These medications are calcium disodium ETTA and dimercaprol, also known as British anti-leucide or BAL. In comparison to Suximor, these have significant adverse effects and require a higher level of monitoring, which is why they're used for inpatient treatment. Next slide, please. So after you have performed the recommended actions based on the blood lead level, you can use a schedule for follow-up testing. The goal for follow-up testing is to ensure that additional exposure to lead has been stopped and your medical recommendations and interventions are working. You should also use your clinical judgment based on the patient's symptoms or if the risk of lead exposure has changed when applying these guidelines. For patients with high lead levels requiring chelation, please consult a medical toxicologist or pediatrician with experience managing lead poisoning for monitoring of follow-up blood lead levels, because they will need to be determined on an individual patient basis. Next slide, please. This slide lists some useful resources. Everything that we talked about today can be found on the CDC website. The American Academy of Pediatrics also has information on lead exposure and recommendations on their website. The PESU website has contact and locations for referral resources by region, and their website is www.pehsu.net. And you can also contact your local poison control center by calling 1-800-222-1222 for assistance. Next slide, please. Great, and I believe that's it, and I will turn it over to Anna.
Thank you. Thank you, Dr. Allwood, and thank you, Dr. Chang, for this important update. And now what we're going to do is we're going to go into our Q&A session. We're going to take one question because I know we don't have much time at all. So please remember to ask a question using Zoom. Click on the Q&A button at the bottom of your screen. then type in your question. And please note that we often receive more questions during the webinar than we're able to answer due to time restraints. If your question is not answered live, you can submit your question to ehnexus@cdc.gov. So I'm going to ask one question because that's all the time I've got, and it's the first question we received. Dr. Allwood, I'm going to direct this question to you. The lead level threshold was lowered from 5 to 3.5 micrograms per deciliter by CDC in 2021. However, some lab corporations are still testing at 5 as the normal threshold. Thus, clinicians can't tell patients, guardians that their children have elevated blood lead levels. How should we address the issue, especially those who work as that work as a child lead poisoning prevention epidemiologist for local counties doing case investigations?
Thank you, Commander, and thank you for that question. We are aware that there's some labs that are not, reporting at the current blood lead reference value, and we have been conducting some outreach through the Association of Public Health Laboratories to try to promote and encourage labs to improve their methods and their reporting to ensure that they are able to detect and report blood lead levels at the reference value. I will tell you that prior to adopting the blood lead reference value, prior to updating the blood lead reference value a year ago, CDC conducted a fidelity assessment of how states and local jurisdictions were implementing the prior blood lead reference value, and that gave us some insights into the fact that in some parts of the country it can take a while for systems to catch up, and so we're going to be conducting some systematic engagements in the next couple of months with our partners in the public health labs and also in private labs, and reaching out to our state and local partners also to try to assess the progress towards implementing the new blood lead reference value, and to provide technical assistance and guidance to ensure that laboratories and clinicians and public health agencies are in fact moving towards the implementation. Thank you.
Thank you, Dr. Allwood. And that concludes our Q&A session. So now I'd like to turn it back over to Dr. Svendsen and Dr. Chambliss for closing remarks. Dr. Svendsen, the floor is yours.
Well, thank you so much, Commander Khan. I just wanted to say a quick thank you to all of our attendees. We appreciate your joining us today. As you've heard, we are committed to partnering with our other public health agencies and colleagues across the country, such as HRSA, to reduce childhood lead exposures across the country. There are people right now working across the country to help eliminate exposures to lead from paint, drinking water, consumer products, and other sources where children live, work, and play. With that, I'll pass it back over to you, Dr. Chambliss.
Dr. Chambliss, the floor is yours.
Thank you, Eric. Thank you, Anna. This has been a very timely and informative session for this year's National Observance of Lead Poisoning Prevention. As we bring this forum to a close, on behalf of the entire HRSA family, the Bureau of Primary Healthcare, I want to thank everyone for joining us for this discussion on the often overlooked issue of blood lead testing, poisoning, and prevention. Thank you to my co-hosts and presenters from CDC, National Center for Environmental Health, and to echo the recommendations made today by our colleagues at CDC, also found in their recent American Academy of Pediatrics article, as healthcare providers, the nation's children and family are depending on you to do three things: continue to inform and educate families about lead exposure throughout day-to-day clinical interactions, help ensure equitable screening, diagnosis, and follow-up for children at greatest risk for lead exposure by following guidelines and partnering with state and local health departments, health systems, and communities to address health disparities. Become a trusted expert in your community, connecting with other trusted voices and speaking out to make change to protect the lives of our youngest patients. For many, this was a refresher course. For others, it may be the first time that you have experienced a comprehensive presentation on this topic. Please share the knowledge with your colleagues who were unable to attend, and when the recording becomes available, please share it widely. Thank you and have a great day. Commander Khan, turn it back to you.
Thank you, Dr. Chambliss. This concludes today's Nexus webinar. Thank you for joining us, and a special thanks to Dr. Svendsen and Dr. Chambliss and the presenters, Dr. Allwood and Dr. Chang. If you have additional questions, you may email them to ehnexus@cdc.gov. Take care and have a great day. Thank you.